All right, team, welcome. Today, we're going to tackle one of the most critical, high-stakes interventions we have in the NICU, therapeutic hypothermia. Look, this isn't just about following a protocol. This is our chance to literally change the trajectory of a newborn's brain after a major hit. So let's get right into it.
So picture this. You're on call. The call comes in. A 38-weeker arrives, floppy, not breathing right, Apgar's in the gutter. You're thinking HIE. From this exact moment, every single second counts. This isn't just some textbook scenario. This is the real deal, and it's where we're starting today.
So why do we do this? The whole idea, the entire reason this therapy exists, is that we're in a frantic race against a devastating cascade of brain injury. Cooling isn't just about making the baby cold. It's about hitting the pause button, giving that brain precious time to protect itself.
Okay, this slide, this is everything. You have to understand this. The initial insult at birth, that's the primary injury. We can't do anything about that. But the real enemy, the thing we're trying to stop, is the secondary wave of injury that starts to kick in about 6 hours later. That little gap in between, that's our golden window. It's our one and only shot to jump in and stop that second wave from happening.
So who actually gets cooled? The criteria are incredibly strict, and for very good reason. We're looking for term babies, so 36 weeks or more. They need to have stone-cold biochemical proof of a major event like a really, really bad cord gas. And critically, their clinical exam has to scream moderate to severe encephalopathy. You need all three of those pieces, no exceptions.
All right, let's get into the nitty-gritty of the protocol itself. I like to think of it in terms of the core numbers. These are the numbers you absolutely have to burn into your memory. They're going to be your North Star when you're managing these kids.
First up, the entry ticket, gestational age. We're only talking about infants at 36 weeks or older. As we're going to see in a bit, this number is non-negotiable, and it's backed by some really strong and recent evidence.
Next, the target. We're aiming for a core temperature of 33.5 degrees Celsius. And I mean exactly 33.5. Not 33, not 34. Precision is absolutely everything here. It's all about that perfect balance between being effective and being safe.
And for how long do we keep them there? The standard is 72 hours. That's 3 full days of controlled, sustained cooling to give that brain the absolute best shot it has at healing.
Now, a question I always get is how do we actually do it? Well, there are two main ways. Whole body cooling with a special mattress or selective head cooling where a little cap cools the brain. So which one's better? Well, the surprising answer from all the big trials is neither. There's no real difference in outcomes. Honestly, the best method is the one your unit knows inside and out.
Okay, after those 72 hours are up, we start what is, I think, the most dangerous part of this whole thing, rewarming. You absolutely cannot rush this. It has to be slow and steady. We're talking no more than half a degree Celsius an hour. If you go any faster, you risk total metabolic chaos, seizures, and basically undoing all the amazing work you just did.
So, after all that trouble, does it work? Oh yeah, it works. This chart says it all. Without cooling, the odds of death or a major disability are a staggering 65%. With cooling, we knock that down to 45%. A 20% absolute risk reduction. I mean, that is a home run in medicine.
And here's another way to look at it that really drives the point home. The number needed to treat is just 7. Think about what that means. For every 7 babies with moderate to severe HIE that we cool, we save one of them from either dying or having a major lifelong disability. That is unbelievably powerful. Of course, this therapy isn't without its risks. While we're busy protecting the brain, we have to be hypervigilant. You need continuous EEG because these babies love to have seizures that you can't even see. You also have to expect the body to react. A slower heart rate, a drop in platelets, that's pretty standard stuff. But the one thing you must avoid at all costs is overcooling. The second you dip below 33 degrees, you're flirting with disaster, serious arrhythmias, PPHN, really bad stuff.
So we've gone over the established rules, right? The textbook stuff. But medicine is never that simple. It's always changing. So now let's look at how some brand new trials are making us ask some pretty tough questions and, honestly, change the way we practice.
So here's a quick snapshot of what's been happening. Researchers have been pushing the envelope, asking, what if we tried this on preterm babies? Or what about kids with just mild HIE? Or what happens if we start late? And the answers we're getting are really shaking things up.
Let's start with the biggest news. It's a bombshell, really. A huge trial just looked at cooling late preterm babies, so 33 to 35 weekers. The result? It was crystal clear. Not only was there zero benefit, there was actually a signal of potential harm. This is practice-changing, folks. We do not cool infants less than 36 weeks. Full stop.
All right, what about the other end of the spectrum? Babies with only mild HIE. It seems kind of logical, right? If it works for the severe cases, maybe it'll help the mild ones too? Well, the evidence just isn't there. The data shows the benefit is really uncertain, and it brings up this huge concern that we might be over-treating these babies. So right now, routine cooling for mild HIE is not the standard of care.
And what about that sacred 6-hour window? Is there any wiggle room? Can we stretch it? The data says, nope, not really. While there might be a tiny bit of benefit to starting late, the trials have been pretty clear. Kicking off cooling after that 6-hour mark is way, way less effective. That window isn't a guideline, it's biology.
Okay, let's pull all this together. What does it all mean? Well, the core of our practice is as solid as ever. You cool term infants with moderate to severe HIE, and you do it within 6 hours. But all those gray areas where people were starting to drift, cooling preemies, cooling mild HIE, starting late, that's all being reined in by some really good, hard evidence.
All right, let's boil this all down. What do you really need to know? I want to give you the key pearls, the stuff you need for your exams, and, way more importantly, what you need to know for your next shift.
So if you forget everything else, please remember these 4 things. 1, the 6-hour window is sacred. Don't miss it. 2, we do not cool preterm infants, period. 3, for mild HIE, it's controversial and should not be your routine. The evidence isn't there. And 4, a super practical tip. If a baby is being transported to you, make sure they're on active servo-controlled cooling. It's so much better than just passive cooling and gives that kid the best chance by getting them to the right temperature before they even get to your door.
And I'll leave you with this thought. Therapeutic hyperthermia is, without a doubt, one of the biggest leaps forward in neonatology in decades. But what all this new research is teaching us is that our job now is to use this incredibly powerful tool with more and more precision. The future isn't just about making babies cold anymore. It's about figuring out exactly who to cool, when to cool, and then asking, what's next? What other therapies can we add on to protect these tiny, vulnerable brains even better?